Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. So today we're gonna talk about pneumonia. Very high yield, um, very important topics to cover before you attempt the licensing exam, especially MCQ one. So this is something that you need to know before even thinking about going to the real exam or attempting it. All right, so learning objectives, what you should be able to do on exam day. So, first of all, you have to know the different types of pneumonia that we should expect in the licensing exam to appear. Community acquired pneumonia, then hospital acquired pneumonia, and then ventilation. Someone that who is connected to the ventilation and he develops pneumonia. Aspiration pneumonia, uh, uh, aspiration pneumonitis versus aspiration pneumonia. So we will talk about all the stages when it starts with pneumonitis, pneumonia, then it develops to lung abscess. We will cover all of them. So today it's going to be a little bit long, but it's very important, and I'm pretty sure it is very interesting. And I'm trying my best to make it easier and fun to understand as much as I can. I will try. So use severity, disposition, logic. Remember, there is a curve 65. Well, John, it is not from our side. I can see it. I believe it is from your end that you cannot see the slide. It is from your end. I believe everybody else has this, they can see my screen, right? Yes. Okay. So it is from your side. Alrighty, so try to reconnect. Saneha and Dr. Seb Sohail is co-host. They can let you in if you want to disconnect and just connect one more time. All right, select empiric antibiotic using Canadian stewardship principle and risk factors, MARSA, Pseudomonas, atypical. So we will cover them all. Recognize high yield syndromes uh, like Legionella, post-influenza, MRSA, PGP, and HIV or immunocompromised patient. Identify and manage complication like parapneumonic effusion, empyema, abscess, pneumothorax, non-resolving infiltrates. Apply do not delay antibiotics and sepsis logic, plus early de-escalation, IV to oral switch, duration, follow-up, imaging. So these are the things that we should know by the end of this lecture, and you should know it before you go to real exam. So in terms of pneumonia definition and categories, so as I mentioned before, that we have different types of pneumonia, and we should be able to tell if this patient has pneumonia, what type of pneumonia. Is it community acquired? Is it hospital? Is it ventilation related, or it's aspiration, pneumonitis, or pneumonia? So for community acquired pneumonia, usually it happens in the community. So I think it's self-explanatory when it says community acquired pneumonia, you uh, get it from the community and acquired in the community or presence incubating at admission. So usually the organism that's culprit or the main cause for it is streptococcal pneumonia, H influenza, and it could be atypical. So hospital acquired pneumonia, remember, if they want to test you on this one, they will give you a scenario about someone that who is in the hospital setting for any reason. For example, whether it is like a fracture, whether it is a headache, whether it is like a GI issue or cardiovascular issue or just a skin issue, whatever, for any reason, if the patient is in the hospital and the patient uh, get pneumonia after 48 hours in the hospital, but he's not connected to ventilation. Remember, that's the key. One, the patient is in the hospital for more than 48 hours and he is not connected to ventilation. This is called hospital-acquired pneumonia. If pneumonia happens outside the hospital, it could be community-acquired pneumonia. But if it is within the hospital, but more than 48 hours, it is hospital-acquired pneumonia. But again, he should not be connected to ventilator. Gram-negative Staphylococcus aureus, local resistance, and now ventilator-acquired pneumonia is the one that the patient is in the hospital more than 48 hours, and the patient is connected into ventilator for more than 48 hours. So that's the difference between hospital-acquired pneumonia and ventilator-acquired pneumonia. Okay? Often the MDR gram-negative plus Staphylococcus aureus. Now, aspiration pneumonitis. So pay attention to pneumonitis and pneumonia. Pneumonitis is the reaction that the lung shows against the germ that comes inside the lung. It is also called chemical pneumonitis. Why? Because these anaerobes that when we aspirate goes inside the lung shows the reaction, that injury within the lung or irritation within the lung is called pneumonitis. So it's not pneumonia, but it's a reaction. It is an injury or irritation of the lung, and it happens less than 24 hours. In the first few hours after aspiration, like you see somebody who is unconscious for any reason and he aspirate, and then the patient starts having the symptom. So this is pneumonitis if it is within a few hours of aspiration. It is not pneumonia. It is pneumonitis, which is called aspiration pneumonitis or chemical pneumonitis. Okay? So hours after witness aspiration, chemical injury. The reason they call it chemical pneumonitis because it's a chemical injury of the lung. Usually for this one, remember, they usually love to test you on how you're going to deal with it. Are you going to start antibiotic? Are you going to escalate it to, let's say, like invasive procedures? No. For this, only supportive care. Remember, it might be a question in the licensing exam. They will give you a scenario about somebody that who had a seizure, let's say a seizure, and the patient during seizure aspirated. And now the patient developed the sign and symptom. And the question is, what is the best next step? Now you have antibiotic, azithromycin, you have amoxiclav, then you have amoxicillin, doxycycline, and supportive care. So the treatment for him, within 2 hours of seizure, the patient has sign and symptom of pneumonitis. I just do supportive care, no antibiotic. Now the same patient, if continues to have the symptoms and the patient develops another sign and symptom along with it, and it persists more than 24 hours, 48 hours, and 72 hours, anything above 24 hours is considered pneumonia. So if it is before 24-hour, pneumonitis. If it is after 24 to 72 hours, in some books it says 24 to 48 hours, it is called pneumonia. The same condition. Aspiration happened, it did not improve. Now the patient is on the third day after aspiration, and the patient has sign and symptom. Infection syndrome after aspiration risk often 24 to 72 hours. For this, oral flora are anaerobes, and if you don't treat it, the patient will progress to abscess. Exam traps. Timing matters. If you notice, I was insisting on 2 hours or 4 hours or less than 24 hours because it does matter. In the licensing exam, pay attention to the timing when it comes to aspiration pneumonia. So if it is 4 hours after seizure aspiration, it is pneumonitis, just do the supportive care. If it is 2 to 3 days and the patient has fever and purulent sputum, then the patient has pneumonia. Okay, so it is aspiration pneumonia, not pneumonitis, and you treat it as such. Now, diagnosis, what do you do first? So ABC, oxygenation, work of breathing, perfusion, mental status. Chest X-ray confirms the infiltrate. Look for effusion, lobar disease, cavitation. Labs when indicated, like CBC, electrolytes, creatinine, lactate, F sepsis. But remember, for anyone that who comes to hospital, we need to check the CBC, we need to check the creatinine, especially if we know that we might start the antibiotic, we need to know if the kidneys are actually functioning properly. Culture when severe, we do culture if it is severe, like blood culture and sputum, endotracheal aspiration if the patient is connected to one, influenza testing in season or when it change isolation antiviral. So basically, if the sign and symptom of pneumonia plus myalgia happens in a season it is very common influenza season or it's an endemic area, then in that case you have to check for the influenza. Do not delay antibiotic for test when unstable or septic. Remember, we do not wait for the culture because the patient, if you have a septic patient or very severely sick patient, because you want to see if you can choose the antibiotic. You can start the broad spectrum antibiotic until you receive the culture. Once you receive the culture, then you can de-escalate based on that sensitivity or result of the culture. Let's say the culture is showing that it is sensitive to azithromycin, you start azithromycin, doxycycline, amoxicillin. But if the patient is septic, we do not wait for the culture. We start with broad spectrum, but we do not continue it. We do not continue it. Once we receive the culture result, then we have to de-escalate it. Then based on the culture, we have to move on. So gram stain, many neutrophils, no organism, considered atypical prior antibiotic. Maybe sometimes the patient may, when you do the culture or the sputum, you see many neutrophils, but no organism. So it doesn't mean that the patient does not need antibiotic. Or in some case, it is mentioned atypical, and I made it bold. Atypical, atypical clinical features are very common in elderly. Like for a young adult, we usually uh, for the pneumonia, we usually look for what? For cough, for fever, for sputum, right? So if they have these three, then we think about, or we at least suspect about pneumonia. Why it's called atypical? Because in elderly, if they have pneumonia, they may not start with cough. They may not start with the sputum. They may not start with a fever. Might have something very atypical. For example, they may have delirium. They may start with a delirium. That's why it is called atypical presentation. So remember, if you have atypical presentation in elderly, rule out pneumonia because it could be anything. Why they call it atypical? Because they can present with anything, probably with just headache, probably with delirium, probably with psychosis. So it means that atypical presentation of pneumonia is very common and elderly. Okay, very common. Like when you check the sputum, still it will be atypical finding. Consider the pulmonary emboli, congestive heart failure, asthma, COPD, malignancy when featured don't fit. Older adult, like now, delirium, functional decline, maybe main presentation, rather than cough, rather than sputum production, rather than fever. Say they might just present with functional decline. I'm very tired. I feel tired. I feel fatigue. Or they have delirium, or they have psychosis. Document severity and disposition, rational patient safety domain. So when to culture, this is very important. When do we do culture? We don't do it for everyone. We do it when it is severe community acquired pneumonia or if the patient is in ICU. when we put patient in ICU, if the patient has confusion, shock, cavity disease, MRSA, pseudomonas risk, immunocompromised patient, recent hospitalization, or recent IV antibiotic use, or failure to improve with an optimized treatment. So in these conditions, I would order culture, not in everyone. Severity and disposition. How exam question decide outpatient versus ward versus ICU. Clinical red flags, override score, shock, hypotension, severe hypoxemia, respiratory rate over 30, confusion, multilobar disease, inability to take per oral, rapidly progressive course. So in this condition, we admit the patient. Remember, if your patient, I'm just focusing on one word, this. If your patient has confusion, the patient goes to ICU, okay? Regardless of the rest. If the patient is confused, send him to ICU. Now, curve 65. C stands for confusion, U stands for urea more than 7, and R stands for respiratory rate more than 30, and B stands low blood pressure. So for low blood pressure, I think it's not mentioned here, so I can add it should be less than 90 over less than 60. But remember, it is not always that both systolic and diastolic is less than 90, less than 60. If you have somebody with confusion, urea is more than 7, respiratory rate is more than 30, blood pressure is 89, and diastolic is 60, it's still okay. It's part of the curve 65. So both of them does not have to or necessary to be lower than 90 or 60. It can be also one of them, or it is okay if the systolic is less than 90 or only the diastolic is less than 60. So if you see anyone that only the diastolic is less than 60, again, he is a candidate. If you see the systolic is less than 90, again, he is a candidate. Or age more than 65, higher score, higher mortality. So disposition outpatient. So how, in terms of typical exam cues, so the patient will be stable. The patient will be stable. Oxygen saturation will be okay, reliable follow-up. So for this patient, I will treat it as outpatient. And usually, if I give him antibiotic, it will be oral, as opposed to in ward. If the patient is hypoxemic, the patient has comorbidity, virility, and poor per oral, or the patient cannot eat or drink, then I have to admit the patient and start IV. If the patient can drink and eat, then I will prefer to give him oral and then monitor. ICU if the patient is confused. Remember, ICU confusion. So don't be confused in terms of confusion when it comes to ward and ICU. If you have hospital, let's say if you have somebody that who meets the criteria for the curve 65 and you have admit to hospital and admit into ICU, go for ICU, not for hospital, okay? ICU. If the patient has confusion, goes to ICU, not in the ward. In the ward, when the patient is not confused, but the patient is hypoxic, the patient is able to, maybe able or maybe not able to drink or eat, but the patient has comorbidities like cardiac disease, hypertension, diabetes mellitus, chronic kidney disease, and stuff like that. Okay? So, shock, severe hypoxemia, respiratory failure, resuscitate plus early brought empiric antibiotic. Exam wording. Most appropriate next step often means disposition plus oxygen antibiotic, not fancy test. So it means you have to act quickly. Do not delay the treatment for fancy tests. Clinical bucket. So if your patient is healthy, low risk, or maybe I should also add this. If the patient is healthy, low risk, or uncomplicated pneumonia, then in that case, either amoxicillin or doxycycline. So we're talking about community acquired, right? For community acquired pneumonia, if the patient is healthy, low risk, uncomplicated pneumonia, he has pneumonia, but it's not complicated. The patient is stable. You can treat the patient as an outpatient, like we did discuss it here, right? The patient is stable. The vital is stable. And one more thing, when do you discharge the patient? When the patient vitals are normal. When do you change the IV into oral antibiotic? When the vitals are stable. So same thing. For community acquired, if the patient is healthy, low risk, uncomplicated pneumonia, and the patient has stable vitals, I will discharge the patient with amoxicillin or doxycycline. Either or. Either or. Amoxicillin is usually used for younger generation. Doxycycline is used for the elderly. Sorry. And pec narrow, doxycycline if atypical. Again, atypical, when we say atypical, it means usually if the patient presents with the atypical symptoms like delirium, fatigue, tiredness, psychosis, like which is usually common in elderly. So doxycycline for atypical mostly, and uh, amoxicillin for a young generation, usually when it is typical. Now, comorbids, if the patient has comorbidities, then you escalate it to amoxiclav or atypical agent. Add atypical coverage like macrolide or doxycycline. So if it is comorbidities or if the patient has complication, if the patient has pneumonia with complication, then you can add, instead of only amoxi, you can add the clavinic acid as well, which is going to make it amoxiclav. Or you can add macrolide, or you can add doxycycline. Okay. Penicillin anaphylaxis, obviously, if it is the patient has allergy to penicillin, we don't use amoxicillin, and instead we use doxycycline. So avoid common overuse. Routine broad therapy like carbapenem, vancomycin, and low-risk outpatient is frequent exam wrong answer. So do not use, as I mentioned before, do not use the broad spectrum antibiotic when you have the result and you are going to discharge the patient. So we discharge the patient when the patient is stable, when the patient can eat, when the patient's saturation is okay, not hypoxic, the patient is fine, can walk, right? So I discharge him, but I gave him a medication that is not broad spectrum, like amoxicillin or doxycycline. If I'm using a broad spectrum, then I have to de-escalate it because that's going to be a wrong answer. And usually the IMGs usually go after the wrong, the broad spectrum antibiotic, which is the wrong option. Inpatient community acquired pneumonia. He is inpatient but not in ICU. Covered typical plus atypical, add extra only when risk is real. So for inpatient community acquired pneumonia but not ICU, typical baseline is IV beta-lactam plus atypical coverage. To make it simple, in someone that who is in the hospital who has community acquired pneumonia, but you want to treat him in the hospital, like he is not stable, he is hypoxic, he has comorbidities. Now I have to treat this patient as an inpatient, but what is the best combo? The best combo of IV beta-lactam and atypical coverage, it is ceftriaxone plus azithromycin. It's not the only, but it's the best combo. Okay. The typical inpatient community acquired combo. So reassess when we're treating a pneumonia in the hospital, we need to reassess our patient within 24 to 48 hours. So 24 to 48, if there is another option, 24 to 72 hours, it's also okay. So in different resources, they mention different timing, but most likely 24 to 48 hours is the time that you need to reassess the patient. Why? Because we have to de-escalate the treatment and we have to start thinking about discharging the patient. Because if the patient is improving, if the symptoms are improving, then I have to de-escalate the antibiotic and I have to think about discharging the patient. Do not chase X-ray clearance before discharge. That's another common mistake by IMGs. Like they want to do an X-ray, it might be one of the options. Do the X-ray if it is cleared, then discharge. So we never do that because if you have pneumonia, the changes, if even if you um, recover from pneumonia, the changes in X-ray will still be there, or the changes in lungs, it will still be there if you even do the chest X-ray for 2 to 3 weeks, in some cases up to 6 weeks. So we don't do the chest X-ray as one of the points to decide whether I should discharge the patient or not. So that's not required. Okay. It doesn't have anything to do with the patient's discharge or if the patient is improving. So do not chase X-ray clearance before discharge. Not typical inpatient note. So I did mention this one. Add MRSA coverage when recent hospitalization, IV antibiotic. So if you have a patient that your patient had recent hospitalization, the patient has pneumonia, the patient has pneumonia, and your patient had a recent hospitalization, and or or the patient had pneumonia, hospitalized. Not only that, he was receiving IV antibiotic. Now, for this patient, we need to go for MRSA or add MRSA. So for MRSA, we have two options. I think I added here somewhere. Yeah. So we have vancomycin and linezolid. Linezolid is preferred. Let me write it because it is when it comes to pneumonia, and if you want to add MRSA, it is preferred. It is preferred than vancomycin because of better line penetration. So it is better than vancomycin. So if you have an option that you have, let's say they gave you a scenario about someone that who had recent pneumonia and recent hospitalization and recent IV antibiotic use, what is the best next option or the best next step? So I will add MRSA because the patient has not improved, right? So now I add MRSA. If I add MRSA, now they may give you this scenario that you have already decided to add the MRSA, but which one is the best one to start with? If it happens to have both vancomycin and linezolid, please go with the linezolid. It is more preferred when it comes to pneumonia. When it comes to pneumonia, and you have to add the MRSA, then you have to go with the linezolid. If you don't have it, then vancomycin is the best choice. Okay. All right. Going back to previous one. Yeah. Add Pseudomonas coverage when severe COPD, structural lung disease, periodic Pseudomonas isolation, frequent antibiotic, and bronchiectasis. So for this one, to add Pseudomonas or anti-Pseudomonas antibiotic, Usually they give you a scenario about someone that who had history of Pseudomonas positive. Because once you have the Pseudomonas positive, then it is a risk factor for recurrency. It will happen again. So you will have pneumonia with Pseudomonas again. So that could be an indication for starting anti-Pseudomonas antibiotic. Key principle, broaden early only if indicated, then de-escalate fast once culture or response clarified, which I did mention it a few times. Now, inpatient, I think I did mention this one. So the best combo is ceftazidime azithromycin for anti-Pseudomonas. These are all the anti-Pseudomonas antibiotic. Most commonly used one is piperacillin and tazobactam, and then meropenem and imipenem. These are very commonly used, and ciprofloxacin. But these two, usually, and clindamycin, these are very commonly used for the lung abscess. Just keep it in mind. Now, severe community acquired pneumonia or sepsis. So we treat it as sepsis, right? Immediate oxygenation, IV access, fluid, lactate if, shock suspected, culture if feasible, blood culture plus sputum. So basically for sepsis, we do all the cultures, do not delay antibiotic. Again, we do not delay it for the culture result. We started empiric broad regimen guided by the local resistant MRSA, Pseudomonas risk, early ICU involvement for the shock or respiratory failure, reassess for complication. What are the complication? Effusion, abscess, pneumothorax. These are the things that I have to look for and be cautious for. Common MCQ1 stem. So remember, confusion, hypotension, respiratory rate over 30, oxygen saturation less than 90, ICU. Regardless of the rest, confusion, ICU. Okay? Confuse, ICU. Immediate antibiotic plus resuscitation. Don't miss post-influenza necrotizing pneumonia. Think MRSA. If you have necrotizing pneumonia, the patient may have hemoptysis, rapidly declining, multilobular infiltrates. These are the key cues or clues that they will mention in the scenario. If you see it, it is usually necrotizing pneumonia, and you have to think about MRSA. Now, atypical pneumonia. Now we have atypical pneumonia, which is one of them is an elderly. Now we have a few more syndrome that they also have atypical presentation. One of them is Legionella pneumonia. So for this, usually if they want to test you on this one, pay attention to the scenario. These are the clues. The patient has pneumonia, but remember, but the patient has history of travel. That's why when it comes to narcolepsy, we have to ask, have you had any travel recently? This is why it's very important in narcolepsy to ask. Why? Because I want to rule out Legionella pneumonia. Okay, so in the MCQ one, they give you a scenario about someone that who recently had a travel somewhere, and after return, the patient developed, remember, developed GI symptoms before pneumonia, diarrhea, especially diarrhea, or vomiting. Then the patient developed pneumonia. So, history of travel, first GI symptoms, then pneumonia symptoms. History of travel, then GI symptoms, then pneumonia. Now, this is Legionella. And what is the treatment? The treatment is macrolide, like azithromycin or doxycycline. And they love to test you on this. That first, what is the most likely diagnosis? If you have somebody who traveled, then GI symptoms like diarrhea, now the patient has pneumonia. What is the diagnosis? Legionella. What is the best treatment or best medication? Macrolide or azithromycin. You have another option. If you don't see azithromycin, go for doxycycline. But usually, azithromycin is the first best choice. First best choice. Okay. And now a different scenario. You have young adult, dry cough, and headache. Headache. It is atypical to have headache and pneumonia because we are not looking for headache and pneumonia. We're looking for cough, sputum, and fever, right? Headache is atypical. That makes it atypical pneumonia. So we have young adult, the patient has dry cough, and the patient has headache. Now, this is mycoplasma pneumonia, and the treatment is the same, doxycycline or macrolide. But if they ask you which one is the best one, doxycycline. Azithromycin is also a good choice, but the first best choice will be doxycycline. And seasonal abrupt myalgia plus pneumonia. Influenza, obviously, because it is seasonal, and secondary bacteria. Based on that, we decide to use antiviral or antibacterial. Interpretation pairs many neutrophil, no organism on gram stain. So neutrophil is supporting pneumonia, but may suggest atypical or prior antibiotic. So do not stop the therapy. If you see neutrophils but no organism, it does not mean that you don't need to start the antibiotic or you should stop the antibiotic, continue the antibiotic. Post-influenza, I think it's very straightforward. So the timing worsen after initial influenza. Usually the patient has sign and symptom of like flu, then develops into pneumonia and improves within 3 to 7 days, features hemoptysis, pleuritic pain, severe hypoxemia, shocks, imaging multilobular infiltrate, necrotizing cavity changes, management ICU, empiric MRSA agent, and added to severe community-acquired pneumonia regimen. MRSA risk factor, practical, non-prior MRSA, recent hospitalization. I think I did mention this. Usually for this, they give you a scenario about somebody who had recently hospitalization. Not only that, IV antibiotic. Think about MRSA. Why it matters, delay MRSA coverage in true necrotizing pneumonia, increase mortality. So why does it matter? If you have a patient who had hospitalization and IV drug, IV antibiotic, now he has even worse pneumonia. So, because if you don't start the MRSA, the patient will not well, might die. So it increases the risk of mortality if you delay the treatment. De-escalate if the culture is negative, clinical course supported. Now, when to cover Pseudomonas? Pseudomonas, prior Pseudomonas isolation. Like if you have a patient, let's say they gave you a scenario about somebody that who has pneumonia, but he has a history of pneumonia, which he did test, and Pseudomonas was positive. So the positive history of Pseudomonas is a strong predictor of the recurrence. It means if you have it once, it will happen again. So for me, it is Pseudomonas until proven otherwise. So I treat it as such until the culture comes back. Past sputum grew Pseudomonas. Structure lung disease. Colonization, repeated antibiotic. The patient usually have history of repeated antibiotic. Severe COPD and bronchiectasis. This is the exam cue. Like usually they give you a scenario about somebody that who has severe COPD and bronchiectasis and history of what? Repeated antibiotic. So there should be structural lung disease. Frequent antibiotic selection pressure, multiple course last year, recent hospitalization, nosocomial flora shift, recent IV antibiotic. Stewardship principle covers Pseudomonas only when risk is credible. Culture de-escalate. Again, if I have somebody that who is here and he is seeking treatment, but he has history of Pseudomonas pneumonia, then I have to treat it as such until the result comes back. Once I see the result, then based on that, I will de-escalate. If it is Pseudomonas, I will continue it. If it is not, then I will stop and change my antibiotic treatment based on the result. Aspiration pneumonia. Again, I think I did mention this. If it is a few hours, it is pneumonitis. It is called aspiration pneumonitis or chemical pneumonitis. It's not pneumonia. But if it is more than 24 hours and the patient has cough, the patient has fever, purulent sputum, then it is aspiration pneumonia. Now, the patient with a aspiration pneumonitis, usually the patient does not have fever, but for pneumonia, fever. Sputum, not positive in pneumonitis, but positive with pneumonia, and it will be purulent. And treatment, we usually do supportive, but for the pneumonia, obviously we have to use antibiotic. So when anaerobes matters, poor dentation, put right sputum, lung abscess, necrosis, severe periodontal disease, or classic aspiration pneumonia phenotype. Immunocompromised pneumocystitis, immunocompromised pneumocystitis. So this PGP is very commonly tested in HIV. When we do the infectious disease, we will talk about the PGP and how to prevent it, how to do the prophylaxis, and but here we're going to touch very lightly about the treatment. So subacute 1 to 3 weeks, progressive dyspnea plus dry cough plus low-grade fever. Hypoxemia out of proportion to chest finding, diffuse interstitial chest X-ray. The risk usually, or the clue that they usually use in the scenario, they will give you a scenario about someone that who has history of HIV or immunocompromised, any kind of immunocompromised condition. Now the patient has uh, pneumonia, sign and symptom of pneumonia, and he's getting worse. And the thing that they give you as a clue is the CD4. And usually the CD4 will be less than 200. Transplant, prolonged steroid, and chemo treatment. For this one, trimethoprim, sulfamethoxazole. Add a steroid if significant hypoxemia. So a steroid is not a necessary or a must add on treatment. It is based on the severity of hypoxemia, but the treatment is trimethoprim, sulfamethoxazole. It is for pneumonitis and immunocompromised patient. Okay, not for everyone. Trimethoprim, sulfamethoxazole is the best choice for pneumonitis and immunocompromised, like HIV. Think of it when the community-acquired therapy should work, but the pattern is interstitial plus subacute. Differential pitfall. Pulmonary emboli can cause hypoxemia, but PGP has subacute course plus diffuse interstitial infiltration and often elevated LDH. This is how you differentiate it. The exam phrase, remember this is very commonly mentioned. CD4, 120, dry cough, diffuse interstitial infiltration. It is PGP until proven otherwise. So you have a patient with HIV or any sort of immunocompromised condition. So CD4 is less than 200. Dry cough and diffuse interstitial infiltration. It is PGP until proven otherwise. Okay? As soon as you see the CD4, think about PGP and the patient has pneumonia sign and symptoms. Complication, pleural effusion and empyema. Suspect with pleuritic pain, persistent fever, decreased breathing sound, and dullness. So dullness, obviously, pleural effusion. Image, chest X-ray, ultrasound to confirm. Look for the loculation, trochosynthesis if moderate to large. Clinically, so obviously, if you have pleural effusion, you need to do the trochosynthesis. You need to know what you're dealing with and what kind of antibiotic is more sensitive to that. Complicated effusion clues. Remember, if you have pleural effusion and it's complicated effusion, these are going to be mentioned in the scenario. Low pH, low glucose, high LDH, plus gram stain positive. Management, chest tube drainage plus antibiotic. So do not rely only on antibiotic. You need to do the drainage plus antibiotic. Not only to help with the antibiotic, to see if the antibiotic is the choice. Because sometimes that might be a very sensitive antibiotic for that, but the amount of the effusion is so much that antibiotic cannot take care of it on its own. So you need to do drainage and antibiotic at the same time. So when I do the drainage, not only I'm helping with antibiotic, I'm trying to find if this is the right antibiotic for this patient, or if it is complicated or I have to escalate it. High yield decision point, moderate effusion plus pneumonia, thoracentesis to decide if the chest tube is needed. That's another thing which I forgot to mention. Don't do uh, don't do wait 6 weeks when pleural fluid suggests infection. Drain early. So common mistakes, like, and the reason I put this wait 6 weeks, I have seen it in so many question bank that lots of INGs got it wrong, and they were like, it is pleural effusion, it is moderate, it's not too much, so just wait for 6 weeks, see what happens. So do not wait for 6 weeks. Do the thoracentesis and see if you can help the patient early than rather than late. So the clue for complication to abscess and other non-responders. Recognize the radiology word. Cavity plus air fluid. So these are the clues that they mention in X-ray. If you see someone with a pneumonia sign and symptom, and then the X-ray finding is saying about cavity and air fluid, it is lung abscess. Prolonged antibiotic, consider anaerobe drainage if needed. Okay, so usually for the lung abscess, drainage plus antibiotic is required. Usually, I'm not saying always, I'm just saying usually it helps to help with the antibiotic, I mean the drainage. But remember, the cavity plus air filled air fluid level, cavity. This is lung abscess. And if you have anyone with the pneumonia sign and symptom, and suddenly the patient develops pleuritic pain and unilateral uh, uh, decline in heart breathing sound and hyperresonance, obviously it is pneumothorax, immediate assessment plus imaging plus management. Persistent opacity. So please memorize these words, okay? Persistent opacity in a smoker, it is obstructive or obstructing lesion, okay? You have persistent opacity for 6 to 8 weeks, and the patient is not only having pneumonia, the patient has history of smoking, or the patient is actively smoking. The patient is smoking, pneumonia, and the patient has persistent opacity for 6 to 8 weeks. Now, for this one, what's the next best step? CT, chest CT, and consider bronchoscopy. Why? Because it's obstructing lesion. Okay, so if you see pneumonia, smoker, and or persistent opacity, do CT scan and bronchoscopy, because this is obstructing lesion. No improvement after at 48 to 72 hours. It is a wrong bag. It is complicated. Reassess, culture, image for the effusion or offset. Any pneumonia that you're treating has to improve within 72 hours, the most. Like the least, they have to start showing some improvement by 24 hours. The least is, the most is, yeah, the least is 24, the most is 72. So if the patient does not improve by 72 hours, it means you got the wrong diagnosis. This is the wrong bag or organism. You need to reconsider your diagnosis and reconsider your treatment. So it might be something really serious. Okay? The patient has to improve, regardless of what we are dealing with. If it is anything with infection, anything that has to do with infection, the infection has to improve with the antibiotic within 72 hours. Without regardless of like if it is pyelonephritis, if it is UTI, if it is pneumonia, if it is anything, the patient has to improve within 72 hours. That is the time uh, window for the use of antibiotic to show it is result or effectiveness. Antimicrobial stewardship, exam high yield, narrow early, switch early, treat short when safe. De-escalate, I think we did talk about this. Culture identify susceptible pneumococcus, narrow target beta-lactam, avoid just in case. Broad therapy once data return. Like sometimes, not in Canada, I'm not talking for you guys. I'm talking for myself on my own behalf. That I have seen a few people back home that they are doing the antibiotic therapy just with the mentality of just in case. I'm going to use this as broad spectrum antibiotic just in case if this is also the issue, if this is all the issue. But it's wrong, ethically wrong. So we don't do that. Yes, we do it, but at the beginning when we don't have the culture. Once we see the culture, there's no just in case. We have to de-escalate it and make a proper antibiotic regimen therapy. So IV to oral. So we start with with IV antibiotic in the hospital, but it doesn't have to be continuous. We have to switch it to oral. But when do we switch it to oral? Once my patient is improving in terms of vital sign. If the blood pressure is normalizing, if the oxygen is normalizing, if respiratory rate is normalizing, if the heart rate is normalizing, now this is one of the best or most commonly tested topic in the licensing exam that the patient is an IV, and now when you change it to oral, what is the requirement or indication for the switching from IV to oral if the vital signs are improving? Okay. So if the vital signs are improving, if the patient is able to take the medication orally, and if it is not complicated, I will switch it from IV to oral. Why short matters? Less duration. Duration uncomplicated community-acquired pneumonia. This is another thing that might be in the licensing exam. That's why I made it red, because it's important to know the duration of uncomplicated community-acquired pneumonia. So the minimum is 5 to 7 days. It is the minimum. I'm not talking about maximum. It is the minimum 5 day. Okay, minimum 5 day. So even if your patient starts to feel better, you still have to encourage your patient or educate your patient that he still has to finish the antibiotic. Otherwise, the resistance will happen. So there might be a question that you have a patient, your patient is improving. Now you switch it to oral. What is the minimum time of oral antibiotic as an outpatient? That will be 5 days. Okay, 5 to 7, but in some books they never mention 7. 5, they will mention 5. But if you see 5 or 5 to 7, that's your answer. So do not extend because WBC chest X-ray lag behind clinical recovery. Because why? Because X-ray will not show normality. It will still show abnormality for a few weeks. So that is not any indication to stop the medication or do not discharge the patient. Uh, why short? Why do we start? We give the patient antibiotic and we give it for a short period of time because, most of the antibiotic we use, like fluoroquinolones, for example, amoxicillin, they all come with a side effect of Clostridium difficile uh, side effect. Fewer adverse event, less resistant, core Canadian stewardship message. Now, follow-up imaging. Chest X-ray often remains abnormal for weeks. That's why this is not a criteria to decide whether I should let my patient to be discharged or not. Or sometimes, as I mentioned before, that some of the IMGs, they think that once the chest X-ray is cleared, then I can discharge my patient. That's not the case. So you don't have to go after the chest X-ray to decide whether you want to discharge your patient or not, because it's going to be abnormal for weeks. You cannot um, keep your patient in the hospital just because the chest X-ray is not clear. Do not use it to decide cure in the first days. Repeat chest X-ray only considered at 6 to 8 weeks in a higher risk patient. I will do, if my patient is improving, I will not even bother doing another chest X-ray. But for high risk patient, even if my patient is improving, I just want to see how it's doing. I would consider to do it in 6 to 8 weeks if my patient is elderly, if my patient is a heavy smoker. Now, for that patient, you can consider doing it. But other than that, if the patient is improving symptomatically and the symptoms are gone, then you don't need to do any chest X-ray. Okay? But you do it if the patient is elderly, if the patient is a smoker, heavy smoker, then in that case, you can consider it. Persistent opacity or hair abnormality. Remember, persistent opacity, when we say persistent for 6 to 8 weeks, this might be a question in the licensing exam. If you see persistent opacity or hair abnormality, the next best step for you is to do the chest X-ray. Why? Because it may show obstructing lesion. Early imaging if worsening or suspect complication for effusion, abscess, pneumothorax. Prevention, vaccination plus risk reduction plus testable counseling. So these are the things that may help you a lot with counseling if you're doing NACOSCI, that you cannot forget before you discharge your patient. So this would be part of your consultation, that you can go, but you need to get these vaccination done. You can go, but remember that you are smoking. You need to think about stopping smoking. But remember that we are always here to help you if you need to quit smoking. And also hygiene. But in MCQ1, probably the question would be the influenza vaccination annually, especially for whom? For which population or categories? 65 and above, pneumonia likewise, smoking cessation for all the smoker, hygiene and infection for everyone. Counseling phrase for MCQ1 and NACOS here recommend the annual influenza vaccination and age risk appropriate pneumococcal vaccination, reinforced smoking cessation. Now, MCQ1, exam strategy, high pneumonia question, or belt. So, the STEM clues. Confusion. What do you do for confusion? ICU. Remember, don't even think about the rest. If the patient is confused with pneumonia, he goes to ICU. Confusion, hypotension, and respiratory rate more than 30, severe community-acquired pneumonia or sepsis, I will admit the patient in ICU, oxygen, antibiotic culture. If my patient has pneumonia, my patient recently had a travel or he stayed in a hotel and then he developed GI symptoms like diarrhea, then he developed pneumonia symptoms. It is Legionella pneumonia until proven otherwise. It add atypical coverage and the best treatment is azithromycin. The second best is erythromycin. Post-influenza, hemoptysis, necrosis, it is necrotizing pneumonia, MRSA, and ICU. Witness aspiration, 4 hours, less than 24 hours. It is aspiration pneumonitis or chemical pneumonitis, supportive treatment. Now, if it is more than 24 hours and the patient develops fever, purulent sputum, then it is aspiration pneumonia, not pneumonitis, pneumonia. Now, effusion plus low pH, low glucose, which I forgot, plus gram stain, empyema, chest tube drainage. Now we have a few scenarios to just help you out to see how you can diagnose and treat the patient. You have 45-year-old returned from Hodel. The patient had travel. So from Hodel conference, now the patient has fever, cough, dyspnea, watery diarrhea, confusion, lab shows this is what I forgot. This was actually a lot of MCQ1 question banks. What is the electrolyte abnormality in Legionella pneumonia? Remember, it is hyponatremia. Okay, maybe I should put this conference. Now the patient develop what? Okay. So you have 45-year-old patient who returned from Hodel. Hodel, it means the patient had the travel, stayed in a hotel, right? Then the patient developed GI symptom, right? Then the patient developed, or maybe this way so that you know that the GI symptom starts first. Now, okay, 45-year-old, returned from Hodel conference, watery diarrhea. So it is GI, right? GI symptoms. Then the patient developed fever, cough, dyspnea, confusion. Lab shows hyponatremia. Chest X-ray shows patchy bilateral infiltration. Patchy bilateral infiltration. So what is this condition? Legionella pneumonia. So ask yourself, exposure, systemic clues, atypical coverage, best empiric is macrolide azithromycin for the intracellular coverage. So why this is tested? Legionella is the clue stack diagnosed travel, watery diarrhea, plus GI symptoms, hyponatremia. MCQ1 often asks for the single best antibiotic choice. What is it? Azithromycin. Okay. I hope you guys now got the Legionella pneumonia. Usually the patient will have history of travel, come back with the GI symptoms, then the pneumonia symptoms develops, and one of the most important electrolyte imbalances, hyponatremia. Please do not forget it. It might be an MCQ1 question only. They may ask you, they may give you a scenario about Legionella, and they may tell you that which one of the following electrolyte imbalance is most commonly seen in this condition, and it will be hyponatremia. And they might even ask you, what is the best choice? Azithromycin. What is the second best choice? Doxycycline. What is your diagnosis? Legionella pneumonia. Now, moving on to second case. You have a patient who has seizure. During seizure, the patient aspirated gastric contents. And now, 4 hours later, the patient is hypoxic, new dependent infiltrates, the patient is afebrile, WBC is normal, symptoms start rapidly after the event. What is this? Is it aspiration pneumonitis or it is aspiration pneumonia? It is pneumonitis. Why? Because it's less than 24 hours. The patient does not have systemic symptom. The patient does not have fever. The patient does not have cough. The patient does not have sputum. The WBC is normal. And it's less than 24 hours. So the best initial treatment for this patient will be supportive treatment. Oxygen airway protection monitor reassess at 24 to 48 hours for evolving infection. If it starts to evolve, get worse, that is going to be aspiration pneumonia. But if it becomes better, then it is pneumonitis that was treated with supportive care. When to start antibiotic? If the patient starts to have fever, leukocytosis, purulence, sputum, or clinical deterioration, suggest aspiration pneumonia. In that case, you can start antibiotic. Another case, influenza-like illness for 5 days, obviously, so it's going to give it away. Now rapidly deterioration. The patient is hemoptysis, shock, physiology, severe hypoxemia, multi-lobular infiltrates, and necrosis. The question, so this is necrotizing pneumonia, secondary to influenza. So what do we do? MRSA. Which one of the MRSA is the best one out of the linezolid or vancomycin? The best one is linezolid. But if you don't have it an option, vancomycin plus ICU care culture de-escalate if MRSA is not supported. Avoid traps question. Do not choose narrow outpatient agent. Wait for the culture. Never ever wait for culture. Start the treatment and then de-escalate it based on the culture result. Quick reference. High yield triggers you can memorize. Moderate diffusion, complicated diffusion. If it is moderate, it's usually complicated. Trachosynthesis, drain F, pH is low, gram-positive, and low glucose. Gravity, air fluid level, it is lung abscess. Anaerobe aware regimen, prolonged course, many neutrophils, no bags, atypical, prior antibiotics, so keep empiric antibiotic therapy, include atypical coverage. Prior IV antibiotic, recent as hospitalization, MRSA. Severe COPD, prior pseudomonase. The risk of pseudomonase pneumonia is high. Use anti-pseudomonasal agent plus de-escalate. Take home summary. I know it was long lecture. So classify. First, you have to know that we have three different types of, not three, but three commonly tested pneumonia, which is community acquired, hospital acquired, and ventilation acquired. Community acquired if you're in the community, not in the hospital. A hospital acquired if you are in the hospital for more than 48 hours, but you're not connected to a ventilator. That's hospital acquired. But if you're in the hospital for more than 48 hours and you're connected to ventilator for more than 48 hours, that's ventilator acquired pneumonia. Okay? Then we have aspiration pneumonia and aspiration pneumonitis. The first stage of pneumonia is pneumonitis. So if somebody who aspirate and starts to show some symptoms, but not systemic symptoms, the patient is having pneumonitis or chemical pneumonitis, or if it happens anywhere before 24 hours or within 24 hours after aspiration, it is called chemical pneumonitis. Unless the patient develops cough, sputum, fever, then that is aspiration pneumonia. Disposition is about physiology, shock, confusion, hypoxemia. If you see anyone shocked, obviously goes to the ICU. If you see anyone with confusion, he obviously goes to ICU. And if you see anyone with a hypoxemia, goes to ICU. Outpatient, narrow the treatment. If you're treating the pneumonia as an outpatient, two best choice, amoxicillin, doxycycline. If the patient is penicillin sensitive, then you go with doxycycline. But remember, for outpatient, community acquired, uncomplicated, the patient is stable, the patient has no complication, the patient is doing well, can eat, and he has no allergy to penicillin, amoxicillin, or doxycycline. Now, for inpatient, the history is different. What is the most common combo? Ceftriaxone plus azithromycin. It's the best combo. But depending on the specific condition, we decide. Like if the patient had recent hospitalization and IV drug use, I will start the MRSA, vancomycin or linezolid. Which one is the best? Linezolid, especially for the pneumonia. If the patient had history of pseudomonas, now I treat it as such until the culture prove it otherwise. Legionella, the patient usually has history of travel. Then after history of travel, the patient develops GI symptom. Then the patient develops the pneumonia symptoms. That's Legionella. And one more thing, that Legionella pneumonia has very specific electrolyte imbalance, which is hyponatremia. And the best treatment for this is azithromycin, and the second best treatment is doxycycline. Post-influenza, if the patient after influenza develops hemoptysis, necrotizing pneumonia, MRSA. GPG, usually an immunocompromised patient, HIV patient, the CD4 is going to be less than 100, less than 200, and you need to start the trimethoprim sulfamethoxazole, which is also the best choice as a prophylaxis for the pneumonia or PGP in HIV patient. Effusion, moderate to large thoracentesis. If the pH is low, the glucose is low, gram stain is positive, then you need to start draining and antibiotic. Stewardship, de-escalate with the culture, IV, we change or switch the IV therapy or IV antibiotic to oral antibiotic when the patient vital signs improves. The blood pressure normalizes, the pulse normalizes, respiratory normalizes, temperature is normalizing, my patient can eat and my patient can walk and not confused. That is when I'm switching from IV to oral. If you have persistent opacity, the chest X-ray shows persistent opacity for 6 to 8 weeks. My next step will be to do a CT scan because it is representing obstructing lesion. Okay, and follow up, and also chest X-ray, don't use it as criteria for discharging the patient because it has nothing to do with that. The abnormality in chest X-ray might be even positive up to a few weeks after pneumonia. And that's all. I think I covered everything about pneumonia. Thank you very much.